Hello, everyone. Welcome to the Osteoarthritis Action Alliance Lunch and Learn for December. My name is Kirsten Ambrose, and I appreciate all of you taking the time to join the webinar today during the busy holiday season. But before we get started, I wanted to go over a few quick items so you know how to participate in today's event. You will see a control panel on your screen with a few functions. In the audio pane, please be sure that the correct radio button is selected, whether you have joined the event by telephone or with a VoIP headset using mic and speakers. We will have a question and answer period at the end. By default, all of your lines are muted for the duration of the presentation, and I can only unmute one person at a time. So if you want to ask a question, there are two ways you can do that. First, you may type or text your question in the question pane on your control panel, and I will read it aloud to our speaker. Or you may raise your hand to ask a question yourself by pressing the raise hand button. It's that little hand icon with an arrow. Pressing the raise hand button will alert me to unmute your line so that you can speak. If you dialed in by telephone, be sure that you've entered the audio pin as displayed in your control panel so that we can hear your question. If you're using a VoIP headset, be sure your radio button is selected for mic and speakers so that we can hear you. So with all of that, I'm very pleased to introduce our presenter, Dr. Daniel White. He's an assistant professor in the Department of Physical Therapy at the University of Delaware. Dr. White's research interests are in better understanding the determinants and benefits of physical activity in adults with arthritis and people after total joint replacement. Currently, he's working on developing physical activity interventions to promote an active lifestyle in people after total joint replacement. Dr. White is making a return visit to our Lunch and Learn series, so we're excited to have him back. With a slight title change from our announcements, he will speak to us today about pain in knee osteoarthritis and physical activity, the chicken or the egg. Welcome, Dr. White. You may go ahead.
Great. Thank you so much for that introduction, Kirsten. I appreciate it. And it's certainly a pleasure to be back here today to give a talk and give a little update on how the state of the art of physical activity in knee OA has changed in terms of physical activity. Basically, my presentation, I'd like to cover two things. The first I'd like to do is talk about the question, does pain stop physical activity in knee osteoarthritis? And basically, we have an assumption that knee pain is the reason why people aren't physically active, and I want to just take a closer look at that. And then after that, I'd like to move on into looking at the reverse. That is, does physical activity stop pain in knee osteoarthritis? Sort of flip them around and see what evidence exists for physical activity interventions in knee OA. So starting with the first question, does pain stop physical activity in knee OA? We know that knee osteoarthritis is the most common symptom is knee pain, which is results in many functional limitation, especially in older adults, and limited quality of life. However, there's also an assumption that knee pain results in less physical activity. So, in other words, physical activity defined as structured things like exercise and having a period of time where you actually do you walk or you participate in daily activities, and as well as unstructured physical activity, things like you would just do on a normal basis that aren't exercise per se. Anyways, the sum total of these, with participating less in physical activity, results in poor health outcomes, as illustrated by this Grim Reaper here. But my question is, this first assumption that physical activity actually results in less, knee pain results in less physical activity, hasn't really been empirically tested. And this is something I'd like to just spend a moment looking at. And this is hence, this is something that is, for lack of a better term, fact or fiction. So, Dorothy Dunlop has done a wonderful job in looking at physical activity in knee osteoarthritis, and really was the first one to look at objectively measured physical activity in a knee OA population, specifically in a cohort called the Osteoarthritis Initiative. And she used a part of the Osteoarthritis Initiative cohort that had radiographic knee osteoarthritis, and she asked the question, how many of these individuals with radiographic knee osteoarthritis meet the physical activity guidelines, which is basically 150 minutes of moderate to vigorous intensity physical activity over a week. And she found that about 13% of men and 7.7% of women met these physical activity guidelines. And that's a very interesting number to me, because when I read this paper, I said that number sounds sort of familiar. If we go back in the literature, Rick Toriano took a look at a cohort called from the National Health and Nutrition Examination Survey, which is a population-based study of all Americans, anywhere from 18 all the way up to 80 years old. And he looked at, he measured all of these individuals with an accelerometer and looked at their physical activity, and found that basically less than 5% of this sample met physical activity guidelines. So I thought that was intriguing in the fact that just basically a very low percentage of Americans meet our physical activity guidelines, and it seems to be a similar proportion of people with radiographic knee osteoarthritis, as well as the general population, meet this number. So with that knowledge, I went and wanted to take a closer look at this in another cohort called the Multi-Center Osteoarthritis Study, or the MOST study. And this study is comprised of people who have or are at high risk of knee osteoarthritis, and we're from 2 community settings in Alabama and Iowa. And basically all these individuals, around 2,000 individuals from MOST, wore an objective monitor, and we found that less than 10% of the cohort met physical activity guidelines, irrespective of whether they had severe, mild, or no knee pain. It really didn't matter. The same proportion really met the physical activity guidelines. So in this respect, knee pain doesn't really seem to be driving the behavior of meeting guidelines. Now, one limitation to these studies is that these are all cross-sectional epi studies, and we only can take a certain amount of confidence in interpreting these. But I think something else that adds to this sort of hypothesis that knee pain may not be driving sort of physical activity behaviors as much as we think is a preliminary study done by a group by an author, Dept and colleagues from across the pond in the Netherlands. And Dept and colleagues basically looked at people before and after total knee replacement. And basically the study started with 44 individuals who they measured before and after, 6 months after total knee replacement, and they found, as you can expect, statistically significant and clinically meaningful improvements in WOMAC pain and the 6-minute walk test. However, when they looked at the physical activity, they found that pre-surgery, people spent about 5.9% of their 24 hours walking, and 6 months after surgery, this only increased to 6.4%. Which was really not a statistically significant difference and really not a clinically meaningful difference. So this begs a question of saying, well, even after there's dramatic improvements in pain and dramatic improvements in function, people aren't really doing that much more. So in fact, I think at this point, the evidence isn't really suggesting so much that pain from knee osteoarthritis is really driving changes in or less physical activity in this patient population. Now, the second question is, kind of the flip of that. Does physical activity actually stop does physical activity stop pain in knee osteoarthritis? Is there any sort of benefit of physical activity in this patient population to address knee pain? And basically the main question is, why should adults be active? Which I kind of am a little glib with this picture here, but is there any evidence to suggest that people who have painful knee osteoarthritis, in other words, it's not only just the presence of radiographic disease, but their knees actually hurt, is there any evidence to suggest that they should be active and that we should be prescribing exercise to this group? Well, the short answer is yes. Steve Messier and colleagues have some seminal studies demonstrating that physical activity, in fact, is incredibly helpful for reducing knee pain in people with symptomatic knee osteoarthritis, specifically specifically the combination of diet and exercise is extremely effective in reducing knee pain. And this is, basically 17 years of studies that have shown this. And then, in addition to that, I'd just like to put a plug in for, is there any evidence to suggest that diet and exercise can actually prevent the onset of knee pain? And this is something that I, along with my colleagues, took a look at in a secondary analysis of a large trial called the Lookahead study of people who we felt were at high risk of developing knee pain. And I just want to take just a couple minutes just describing this study. Basically, the Lookahead study is individuals who are overweight or obese, and they're middle-aged adults who have type 2 diabetes, and they're randomized into sort of a control group or a diet and exercise group. And we took a look at, and basically they're followed, this is a sort of an intervention where they meet with a counselor and they're encouraged to exercise as well as meet at least a 7% weight loss goal. And this group, basically, we took a look at people who did not report having knee pain at baseline and looked at the percentage of people who developed knee pain 1 year later. And basically, the graph I have here at the top is knee pain at 1 year, and then the N is the sort of the number of people who have knee pain at 1 year and the percentage, and then this second column is the adjusted risk ratio, so the risk of developing pain along with a 95% confidence interval. And our adjusted risk ratio is adjusted for potential confounders. And basically, as I mentioned before, there's two groups. The first group is the Diabetes Support and Education group, which is the control. And there were 1,400 people, over 1,400 people who did not have knee pain that were randomized into that condition. And then the intensive lifestyle intervention group, which is, again, this is the active intervention where people are encouraged to lose at least 7% of their body weight and participate in at least 175 minutes of moderate intensity physical activity, which is typically walking. And what we found, if I cut to the chase here, is that around 300 people developed knee pain, or 22.8% developed knee pain in the control group, and this is our reference group. And in the intervention group, 19.4% developed, so a little bit less. And looking at the relative risk ratio, this was people in the intervention group had 0.85 times the risk, or in other words, they had 15% less risk of developing knee pain compared to those who were in the control group. And so this basically is saying that there seems to be a statistically significant, albeit small, effect of diet and exercise for actually preventing knee pain among people that are high risk. And this is really good news to show that not only is exercise effective for people with existing pain, but people who haven't developed pain but are at high risk. This is certainly a positive note. Now, we also know that physical activity is very effective with protecting against functional limitation. And I just want to take a minute to just describe a study that I, along with my colleagues, recently published that looked at one, is there a dose-response relationship between how much physical activity people do and their protection from developing functional limitation, that is, problems with getting up from a chair, getting out of bed, and climbing stairs, as well as, is there a sort of magic number, or is there a target number that we can give to our patients to help them say, like, if you reach this number, your risk is certainly you have less risk than if you don't reach that number. And so we basically took people from the multi-center osteoarthritis study, and I don't have this in the slide, but basically I show that there is a very strong dose response whereby the more walking that people did on a daily basis had a very strong protective effect with reducing the risk of developing functional limitation 2 years later. And then the second question was, okay, well, what number? Give me a number. You know, we have numbers for blood pressure, we have numbers for cholesterol, what about physical activity? How much walking should people do? And the first question was, okay, well, is there a number that best discriminates people from who end up developing functional limitation from those who don't? And we found that around 6,000 steps per day was sort of the number that was best associated with, that best discriminated people who went on to develop limitation versus those who did not. In other words, people who walked at least 6,000 steps per day were much less likely to develop functional limitation compared to those who walked less than 6,000 steps a day. And this included people, all our participants or most, as well as those restricted to who had symptomatic knee osteoarthritis as well as just radiographic knee osteoarthritis. And then, the clinician side of me, I'm a physical therapist, sort of said, well, that might be a little high. Is there like a sort of first step number that people can go to as a sort of preliminary goal? And what we basically found, the way we asked this question is there a number that if they reach this number, it's very unlikely that the people who reach this number go on to develop limitation. And we found that around 3,000 steps per day, if people reach at least 3,000 steps per day, 95% of them do not go on to develop functional limitation 2 years later. So we believe is a sort of preliminary step goal for someone starting off a physical activity program, that if you give them a goal of 3,000 steps as a first point, that's great, and then obviously try to progress them to around 6,000 steps. And I think what I'm really excited about these numbers are that when I was visiting the clinic, the physical therapy clinic at the University of Delaware, before we had all this data and before I took a formal look at that, the clinicians there put monitors on or pedometers on all their patients, and I was asking them, I'm like, well, what numbers do you give them? And the clinicians there said, look, we'd like to start people, we'd like them to reach a target goal of, I think they said initially 5,000 steps, but if they can get anywhere, above, 2,000 to 3,000 steps as an initial point, that's fantastic. And reflecting back on that conversation I had before doing this paper, I really feel confident that these are sort of solid numbers to give our patients. Okay, so the last thing I just want to spend a couple minutes on is just talking about how to prescribe walking to our patients. And I think just as you would use a scale to lose weight because you need to track where you're going, I think to increase physical activity we need an objective way. The good news is that there are a plethora of pedometers available in the marketplace right now that that are at a variety of costs, from affordable to super expensive. And the nice thing is they all give steps, and using these step goals of 3,000 steps and 6,000 steps is just a nice objective way of measuring progress. There is strong literature to support the use of pedometers as well in clinical populations. A JAMA paper, a meta-analysis in 2007 was done and found that among clinical trials, those who people who were in the pedometer intervention typically walk 2,500 steps more per day compared to the control intervention. And this, just suggests that this pedometer intervention is quite an effective means of increasing physical activity. So, in conclusion, we find, I think that knee pain is not necessarily the reason people with arthritis are inactive. The cross-sectional studies that I talked about show that there's really people are just as inactive whether they have arthritis or not. And we find that after total knee replacement, the preliminary data suggests that despite pain and function dramatically improving, it's not as if physical activity follows suit. It continues to stay low. But we also know that physical activity, is important for the prevention and reduction of knee pain among people with or at high risk of knee osteoarthritis. The Messier studies, the seminal studies looking at diet and exercise in people with knee OA shows that that's incredibly effective, and as well as preliminary evidence from my camp looking at secondary analysis of Lookahead studies show that look, it could be actually be the doctor was right. The fact that he's saying if you're overweight or obese, you should diet, you should get on a diet and you should exercise. Well, that actually seems to be effective for reducing the chance of developing knee pain. Lastly, just preliminary evidence that we have shows that starting people off who have knee osteoarthritis, starting them off with a goal of 3,000 steps per day seems to be a meaningful number for them to reach. And ultimately, you want them to get to around 6,000 steps per day, with the caveat that some people say, well, how much should I walk? Do benefits stop at 6,000 steps? And I think the short answer is that no, the benefits don't stop. There is a dose response where some is good, but more is better, and the benefits will continue as they continue to increase their physical activity. So I'd just like to acknowledge my some current mentors and co-authors. Certainly, this is not this work is a huge collaboration among many different. My work is a huge collaboration among many different investigators and data sets, and just want to give a shout out to those individuals. And that's all I have, so I'd like to just open it up for questions at this point.
Thank you, Dr. White. We had a couple of questions come in while you were speaking, one in particular about the number of steps per day for knee osteoarthritis. Do we have any indication that the number of steps is the same effectiveness for people with hip OA?
Yeah, that's a good question. I don't know. We didn't look at people with hip OA. We just looked at people with knee osteoarthritis. My guess is that there should be a similar effect, although hip OA, Kim Bennell has shown some compelling evidence that suggests that hip OA in rehab might not have as good of effectiveness as we've seen in knee OA. So, I think it's certainly worth a try, and getting a pedometer and getting people active, there's other benefits to that as well. So that's kind of my response for that question.
Mm-hmm. And another question, what do you think are the hypotheses for the reduced physical activity in knee OA patients if it's not pain?
Yeah, I think the key thing is that I think they're low to begin with. I think that overall as a society, our obesity numbers are peaking, and the sedentariness is peaking as well. The CDC has nice data on this, and it's not. It's more of a behavior. It's important to realize that physical activity, unlike pain and functioning, is something we choose or choose not to do. And the reason we choose to do this or not do physical activity is not so much to do with the knee pain, but other factors. We're looking at reasons that people change their physical activity, and there are, some psychosocial reasons, like depressive symptoms, obviously, is one that we seem to see a signal in, as well as, if somebody has a comorbidity, that's another big reason. And actually, obesity is a big reason. People who are not already walking low, if they are walking well, don't walk well over time. It's really a behavior, and it's important just to recognize that as clinicians.
Yeah, I was actually wondering about the behavior side myself, so thank you. Has anything been researched in terms of non-impact exercise, such as cycling, and the benefits for preventing knee OA?
It's so funny, as a PT, like the bike is like one of the go-to things we give to our patients with knee OA. And the last time I looked, there's not a lot of literature on that. There is some small studies that suggest that reducing the weight bearing through biking is definitely beneficial for reducing knee pain. But I wouldn't go to shy away from the walking. I think that Steve Messier has a very clear message that people with painful knee osteoarthritis, and when I talk about pain, most people's pain with knee osteoarthritis is in the mostly mild, some moderate. We're not talking severe pain, and the pain fluctuates. So it's on days that people are not super painful that they start the walking program, and that I think is important to recognize. There also is evidence for strengthening exercise. There's a variety of studies that show strengthening the muscles around the knee, the quads and the the glutes, and hamstrings are effective as well for reducing knee pain.
And there was a follow-on question that was referring to loading of walking and whether the loading of walking is helping keep bones healthy.
Yes, so Steve Messier's actually looked at this, and one, loading the knee in exercise interventions does not speed the disease. It's not like, people who are randomized to this intervention have more joint space narrowing or more bone marrow lesions than those who weren't. Their disease states are about the same. And I think there's a healthy amount of loading that needs to take place that might not necessarily be happening, and hence that's the whole theory behind the whole public health message that things like the Arthritis Foundation are putting out that say get moving or stay moving, and you can hear physicians telling their patients is to continue moving with arthritis. And I think there is a certain amount of loading that takes place during walking that is healthy for our patients to do.
Right, and you referred to walking does not hasten the disease progression. We had a question about hastening the need for a total knee replacement, but it sounds like that's not necessarily the case for walking.
No. I think that it's a quality of life thing, and there is the prehab, so people who are at sort of the end stage of the disease that do exercise. It's not a hands down, well, exercise just helps everybody, but there are some people that do benefit from exercise. But I think the real job of us as clinicians is to help people in the sort of no man's land where they know they have knee osteoarthritis, but they are not ready for a total joint replacement. And I think we need to give them credit and give patients the opportunity to really try aggressive, maybe aggressive is not the right word, but a very explicit exercise program that challenges them and that pushes them beyond their comfort zones that we're kind of used to sticking to, and giving them the opportunity to really try to push themselves with walking and seeing if that is effective with obviously progress them, but I think there's very compelling evidence to suggest that will help reduce their knee pain.
And how about evidence for a combination of strength training and walking producing significantly better outcomes for knee OA than either strength training or walking alone? Strength training versus walking alone.
Yes. So combined programs, I think the Messier studies have combined programs in terms of they do, sometimes it's just strengthening, sometimes it's walking, and sometimes it's both. I think they're both equally effective. I think the main thing that we have to realize as clinicians that is more the issue of adherence. That it's very typical that once we sign off on our patients, they sign off on their exercises, and finding something that is likely to create a behavioral change and that encourages walking after discharge or any sort of physical activity is important. And that's why I guess I'm happy. I'm more likely to recommend the walking, because if you can find some way that people incorporate that into their daily lives, I think the likelihood of them sustaining that behavior post-discharge is higher than if we were to just say, here's some exercises to do. I know they don't. I know you probably won't do these, but at least you can't blame me for not telling you.
Right. Well, we're coming up on our 30 minutes, but we have a few more questions. So if you have a few more minutes, I wouldn't mind getting through them, and then people can kind of sign out as they need to. Is that okay with you?
Yeah, sure, that's fine. And there seems to be like some feedback on the mic or something. I don't know. You're coming in like a little. The audio is coming in a little funky.
Okay, I will. Can you still hear me?
Yes, I can hear. I can make out what you're saying. It's fine.
Okay. Quick question. When you're talking about knee OA, are you referring to medial knee OA only or patellofemoral OA, or have you made the distinction?
Most of these studies, people have they can it's whole knee it's either place.
Okay.
This patient population typically has mainly medial, but there are some of those who have patellar as well, but we don't differentiate between the two. And the cohorts that we talk about include both of those individuals.
So is there any difference in changes in radiologic disease state between people who walk versus people who do not walk? Have you had a chance? Okay.
No, the walking doesn't make it worse. It doesn't seem to. The other flip side is that Kim Benall gave a really nice talk at OAAA this past year in Paris. Besides the fact it was in Paris, and that was really nice. But she showed changes in disease and said that exercise is not slowing the disease process. On the flip side, I saw it as more the glass half full, saying, look, it's not progressing the disease process either faster than it normally would go through.
So going back to our previous conversation about walking not speeding the disease state, what about jogging or running, which are clearly more load on the knee joint?
Yeah, no, that is a good question. I think that I don't know. It's not. These programs are mainly walking activities. They are not running, so it's hard for me to speak on whether somebody, if they start jogging or walking, is that going to speed the disease or not. I don't know. I think what's more important is finding something that people enjoy. So if that only thing they like to do is jog and walking just doesn't do it for them, well, I think that the benefits of doing that versus nothing are good. I think at the same time I try to encourage people to maybe do something, if they like the more vigorous intensity, do something that is less load bearing. So whether that's the sort of proverbial competitive cyclist going from they're all former runners that are now cyclists, doing that sort of thing, or swimming or something else. I think that's what my clinician sense digs into. But there really is very little literature on this sort of running or jogging interventions for people with symptomatic knee OA.
What do you recommend for pain reduction in patients who complain of increased pain when they first begin walking?
Yeah, that's an excellent question. So when you start exercising, yes, it's going to hurt more, but you got to get over the hump. It will get better, and that's the sort of beauty of therapy, is walking people through that valley of, oh my God, my knee is hurting more, but then the more that if they can get through that and then go back and walk, and at the same time you're calibrating how much walking they're doing and pushing them along, they will get better in the long run. These interventions, the Messier studies, are not like 6 or 8 weeks long. These are 18-month interventions. They are long-term interventions, and so in order to get the benefit from sort of exercise, it's not just trying it 1 week and then saying, well, that didn't work. It's persevering through with the help of the therapist in order to really get the maximal benefit out of exercise. And that's sort of my reason for the 3,000 steps as well. It's sort of an initial target goal. It's like, I know you can't get to 6,000, and it's not going to happen overnight, but let's stick a pedometer on you and try to get you up to 3,000 steps.
Well, that's a pretty good segue into when do you suggest implementing a quote-unquote healthy lifestyle program after total knee replacement surgery, and how would you incorporate it with an outpatient PT rehab program?
Yeah, that's a great question, and I'm glad that's being asked, and that's something that we at the University of Delaware are taking a look at, and that's something we want to try to figure out. When people go from that sort of acute phase to the sort of subacute and then chronic phase, what is the best way to sort of start pushing on their physical activity? And I don't have a solid answer for that. I think, though, by the time people are discharged from physical therapy, so once they approach that 1 to 2 month post-op period, I think it's very reasonable for them to be walking at least 3,000 steps per day, if not 6,000 steps per day. I think initially post-surgery, it's more like function and pain that you're dealing with. You're trying to get the range of motion back and address those issues. But I think integrating, we're trying to figure out what is the best point of integration and what makes sense for pushing sort of physical activity, behavioral change on people post total knee replacement.
Do you have any plans for longitudinal studies around the number of steps per day recommendations?
So our study was longitudinal that we did in most. We looked at how many steps people were walking and the association of that with the development of function limitation 2 years later. I think that it's pretty compelling evidence, and I don't think it's so I don't think it's rocket science that people who walk more are less likely to have functional limitation. I think there's other sort of interesting questions that could be asked looking at sort of longitudinal data, looking at changes in physical activity. And in fact, we're working on a paper that looks at, I alluded to a little bit earlier, looking at changes in physical activity from one point over 2 years, and what are the reasons for those changes? Is it disease? And it's not. Is it their sort of depressive symptoms, which seems to be a strong signal? Is it comorbidity? So on and so forth. And that's sort of the next thing that's hopefully going to be off my plate soon and off to a journal pretty soon.
So in your experience, how long does the initial pain that starts at the beginning of a walking program typically last?
Yeah, it shouldn't be long. I mean, honestly, obviously there's an amount of variability, but I think if someone comes in, on a Monday and you give them an exercise program, I think, on Tuesday it should hurt. By the time you see them on Wednesday, maybe they have a little bit more pain than they have on Monday, but it should be better. Hopefully, if you have the luxury of seeing them 3 times a week, by Friday that they should be they shouldn't feel any of the effects from the pain from the exercise on Monday, and maybe they're ready to walk again. If their knee totally blows up and it's just not working, I mean, maybe they overdid it and you need to recalibrate from there. But I'm talking about less than 1 week, definitely less than 7 days. Hopefully, maybe more on the order of 1, maybe 2 days of residual knee pain from initiating a walking program. But that's where we as physical therapists, we're the experts at trying to balance this exercise pain paradigm. And it's just like any other strengthening program. Although the outcome is not muscle soreness, it's more trying to balance out the people's pain, as well as being very sensitive to their sort of psychosocial needs in terms of their anxiety, their fear of movement, and all those sorts of things that we just naturally deal with. And I think it shouldn't be more than 1 to 2 days on average that the pain is sort of lasting.
So we have 2 sort of related questions. One is asking about jogging or running in people with asymptomatic knees and whether that increases the risk for future knee OA. And a second question that says the prevalence of knee OA in runners is low, but does that tend to show a correlation between physical activity and reduced knee OA?
Yeah, these are great questions. I think the ultimate goal is for people to remain active, however they do it, and you want people to be able to do things that they enjoy. Now, for the middle-aged, the older adult who continues to run and says, look, I have no knee pain, but my doctor says my radiographs look, my X-rays look terrible. It's likely that patient will develop knee pain, but at the same time, if they're remaining active, I mean, it's hard to deny that. I think encouraging or trying to have them explore other activities that they might like is a good point. Another thing I think that we as therapists really should try to start taking a stab at is weight, and making a case for saying, look, I fully appreciate this is a very sensitive issue, but the Steve Messier studies really show that it's a combination of diet and exercise, and we know from large epidemiological studies that weight is a huge risk factor for knee OA. So if that runner who's a middle-aged adult, he's put on a couple pounds and is he's not able to tighten his belt as much as he was before. I mean, maybe it's time to think about a diet program in order to reduce the impact load that is going to the knee. And I think as physical therapists, I mean, they're getting this information from everywhere, right? So for diet, why can't we just make the comment of saying, I think, why don't we think about your diet? Why don't we take a look at your BMI and see if we can get that down a little bit? You can, I don't care what way you do it or whatever, but that's just something that we know from the literature is strong. And sort of along those lines, we know that exercise is a great weight stabilizer, that people who are active are less likely to gain weight over time than those who are inactive. And so I think that's really one of the reasons why runners are less likely to develop knee OAs. They keep their weight down just by the fact that they're putting lots of impact throw to their knee, but that's only when they run. When they're walking around like you or I during the daily any regular day, they have 15, 20, 30, 40, 50 pounds, even less, that are going through their knee because they weigh less due to their exercise. So those are just considerations that we don't have the straight answer for, but I think we have definitely some signposts pointing us in the right direction.
Well, and that we had one comment, not a question so much, but that precisely addresses that issue with weight. Just commenting that after joint replacement, people may be more comfortable to go out and eat or meet with friends, and eating being a huge social action for retired population could be an issue, and looking at knee pain and inactivity.
Yeah, exactly. And Joe Zenny and Dan Riddle have these papers that show people after total knee replacement make a clinically significant increase in their weight. And if this is from for more trips, being able to now go out and hit the restaurant or whatever, I think that is a definite fact that people after total knee replacement, on average, gain clinically meaningful amounts of weight. And it's important for us as therapists, now that the pain is gone mainly and that their function is typically improved, now it's important to capitalize on that and try to promote behavioral change. And I think that's the message that gets out. My job now as a clinical investigator is to try to figure out what's the best way for us to do that, or what's effective ways to do that. But I don't think it's rocket science for us it's not rocket science for us to realize now that it's important to promote a physically active lifestyle in people, especially after total knee replacement, where pain and function are definitely not barriers for activity.
And you mentioned that this person mentioned that behavior change seems key. What is your go-to behavior change intervention?
Yeah, I think I think the pedometer is actually, and not only the pedometer, but the sort of permutations of this. So, for instance, if you take Fitbit, a lot of the features of the Fitbit map well onto this sort of trans-theoretical model or other sort of theoretical models of how people make behavioral change. And what I mean by that is, in order to have behavioral change, you need sort of feedback. So the monitor, provides that, and then you need goal setting. And what's nice with the Fitbit or Nike Fuel or Jawbone, whatever, they all have goals of saying, okay, how many steps do you want to walk? And that paired along with the literature of saying, look, 3,000 steps is an initial target, and you want to get up to 6,000 steps. That's another a major thing to provide goals or to facilitate behavioral change. I think areas that we know in physical activity literature in general that's important are to hit more than one level of intervention. So and what I mean by that is, it's not only telling the individual that it's important to exercise, but then getting their family involved. And Joe Zenny and I at University of Delaware actually have looked at the sort of the family support of people after total knee replacement, and actually our preliminary data suggests it's actually quite low. And so as a therapist, treating people after total knee replacement, or even people with knee OA, getting their families involved and on board and saying, this is not a condition of just normal aging, that this is actually very treatable and perhaps preventable problem that, if we can rally their support, the family support, in encouraging healthy eating and exercise, that it's much more likely for that patient to have behavioral change as well as sustain that change over the long term. So those are just some of the things that I think clinically wise are important for us to consider as much as possible.
So one last question that kind of a good segue from your thoughts about using the Fitbit and other assistive devices like that. Have you looked at foot orthotics or trekking poles or things like that, or are there any studies in the literature that have looked at those types of assistive devices or tools to help improve physical activity?
I think that's the short answer is I don't know. I haven't looked. I keep myself so busy with this sort of specific area that I'm in. I think those are all things we can use in our toolbox to treat patients. And if that is something that helps patients, or you believe clinically that makes sense, I mean, by all means, I'd go after it. Again, with the ultimate goal of giving the patient the tools and the support necessary for them to either continue or initiate an active lifestyle. I think that's the most important goal. And if that is using like hiking sticks in order for them to feel comfortable, go for it. If it's like, well, I just want a little more support for my feet, and I'm not an expert in orthotics, but I understand that there's all these different things you can do. If that's what it is, great, I go after it. But again, it's trying to provide that patient, minimize the barriers and maximize the facilitators for them to adopt a healthy lifestyle is the key thing.
Well, this is great. I appreciate you staying a few minutes extra to answer all of the questions that came through. People were hanging on, and we still have quite a few people listening, so I appreciate your thorough thoughts and answers to the questions, and I want to thank you very much again for taking the time so close to the holidays, and for all of our listeners as well for joining us today. Just a quick announcement, you'll receive some information from me about our January 17th Lunch and Learn with Dr. Laura Payne. This was rescheduled from the November original airing date, so that information is on our website. And like I said, you'll get an announcement from me. But for now, I wanted to thank you once again, Dr. White, and wish everyone a safe and happy holiday season.
Great, thanks so much. My pleasure.
Thank you.